I had not started the recording. Okay, so I'll just do a quick. So this afternoon, we're going to talk about unraveling the mystery of pediatric heart disease, including the terminology. To understand the complex terminology used in medical and nursing handover, to review basic anatomical features, to apply the terminology using the cardiac catheterization sheets, to apply the anatomical terminology to a few of the more difficult cardiac defects, and to develop an increased appreciation for increasing complexity of congenital heart lesions. We know there have been significant advancements over the last 50 years, which have resulted in improved survival from improved medical and surgical management, enhanced use of pharmacotherapy such as nitric oxide, sildenafil, phentolamine, milrinone, epinephrine, norepinephrine, dexmedetomidine, better diagnostic and interventional procedures such as cath lab, MRI, echo, and CT, and then needing to be really clear around the communication around the complex anatomy and physiology. So the goal is to simplify, sort out the nomenclature, to demystify, to provide a roadmap to a better understanding of complex congenital heart disease, with an understanding that there's no right or wrong way to describe a heart, and there's just different ways. And really, the goal is to keep the language simple and straightforward. So the terminology can be difficult and can be confusing. So what is acceptable terminology? Well, it should be descriptive and consistent and described as it's observed. We know that abnormally structured hearts can coexist with other cardiac lesions, adding to the complexity. So we really need for an approach that is simple, straightforward, and systematic. With our pathologist, Dr. David Chasen, who we'll see over a series of 10 lectures in the spring session, where we take some of the hearts from children who've died from many, many years back. And Dr. Chasen will take us through the heart. And his sort of systematic way of helping people to understand when you're looking at a heart to sort of make out the different features. He describes, so in the heart pathology specimens, their hearts are actually cut into 4. Some of them are cut differently, but usually there's about 4 cuts into the heart. And he always described it as like opening the pages of a book sequentially, and starting with the right side of the heart. So the first cut into the heart is what he calls page 1, and it's really the inflow into the right ventricle. So we're examining all the bits into the right ventricle. Then we'll move over some of the heart, and then there's the next cut, and that is the outflow, so right ventricular outflow tract, and looking at all the vessels that are attached to it. Then he always asks us to go to the outer cut on the left ventricle, which is the inflow to the left ventricle, and then come back, so that's page 4, and then come back to page 3, where we're looking at the outflow of the left ventricle. So that's just one approach to a systematic, straightforward way of sequentially going through the heart and then understanding what we see. So in your syllabus, you do have the link to the Robert Anderson sessions, which we reviewed the first session of that in the first class. In semester 2, we've embedded a number of Robert Anderson videos into that second part of the curriculum. So here's a systematic analysis. So looking at the systemic and pulmonary veins, looking at the atria. So it's really, for instance, on the right side, when we're looking at what is coming into the atrium, so it should be the SVC and the IVC. When we look at the left atrium, it should be the pulmonary veins. Then going through the atria, the AV connections, the ventricle to great arteries, the connections, the great arteries themselves, and then the visceral positions, so meaning the positions of the lungs and the liver and spleen and stomach. So there's this is actually from a very thick textbook that was produced in 2020. And it has some really beautiful pictures in it. So this describes the three lesions or three areas of the regions of the heart. So we have the atria, the ventricles, and then the great vessels which come out of the right and left ventricles. And each region then is partitioned into right and left. Left-sided and right-sided structures are evaluated for morphology. So we're looking at the chambers, which is what we'll do in semester 2. Today I have some pictures to show you. In semester 2, he will take the hearts and help to sort of go through and examine the hearts and the chambers. So we're looking for, is this a right atrium? Is it a left atrium? Is it a right ventricle? What are the morphologic features that help us to know whether it's the right or left side of the heart? The relative positions to each other, the connections to the proximal and distal segments, and the presence of any location of shunts. So do they have an ASD, a PDA, AVSD, or VSD? And then any obstructions or valvular regurgitation. So what is the sort of morphology of the valves? In terms of cardiac size is relative to the thoracic cage and varies with age. It's approximately the size of the patient's fist. The cardiac thoracic duration on full inspiration is less than or equal to 50%. So we've seen some nice X-ray pictures of cardiomegaly. Accurate assessment of the great vessels by chest X-ray may be hampered by the overlying thymus. So when we're looking at the heart location in the chest, within the thorax, is it left-sided, right-sided, or midline? So we're looking at the position versus so dextroposition versus dextrocardia. So dextrocardia is talking about which way is the apex pointing. Dextroposition is where the heart is in the thoracic cavity. So if the heart were sort of shifted to the right, then that would be dextroposition. If it were shifted to the left, then it's levoposition. If it were more midline, mesoposition. Position of the heart in the mediastinum is affected by cardiac malformation and abnormalities of adjacent structures. It can be displaced also by things that distort the shape of the thorax or diaphragm, such as scoliosis or diaphragmatic hernia. So to give you an instance of diaphragmatic hernia, if you have a hole between your thoracic and your abdominal cage, and in utero you have a lot of bowel that's coming through the opening and it's ending up in the chest, then that is taking up some space in the chest, and that would then potentially, depending on how much bowel is in the thoracic cage, would then cause the heart to shift either more midline or a little bit further to the right. So cardiac position then, direction in which the ventricles are aligned defines the base apex axis of the heart. So level cardia. So normally we have an apex that points toward the left, anteriorly and inferiorly within the mediastinum. In newborns, the apex may be a little bit more horizontal than children. If it's more pointing down to the midline, then that's mesocardia. And if the apex is pointing to the right, then that's dextrocardia. So there's a nice picture of, the atria, the ventricles, and if the head were here, the apex is pointing toward the left, so the usual position. Mesocardia more midline, and dextrocardia in the opposite direction than we normally expect. There's just another couple of pictures with it pointing levocardia, mesocardia, and dextrocardia. We also know that the heart is lined by the epicardial space, and there's some serous fluid that lubricates the heart and allows it to move friction-free. And we know if there's fluid that builds up within the pericardial space, then we end up with a tamponade kind of picture. And remember, if we have tamponade, the heart is being compressed and it just becomes tachycardic because it can't fill out properly and give a good contraction. Other general features are the aorta lies posteriorly, inferiorly, and to the right of the pulmonary trunk. So here we see the right atrium would be up here, the left atrium, the right ventricle, and the left ventricle. And really the valves sort of serve as the cardiac skeleton. So here we have a nice picture of the tricuspid valve, the aortic valve, the mitral valve, and the pulmonic valve. And roughly the two ventricles are similar in size at birth. There's another picture just showing the great vessels. So we see out of the right ventricle, which would be at the bottom of this picture here, the pulmonary trunk as it comes out, and it gives rise to the right and the left pulmonary artery. We have an ductus arteriosus here, and then we have the descending aorta. So from the left ventricle, we see the aorta coming out and curling round and down to the descending aorta. And off the first part of that arch, we have the brachiocephalic artery. So sometimes people call that the innominate artery. And the so we've got the aorta coming up like this. Then there are three great vessels. So the first comes up as a sort of one piece, and then it divides into the right subclavian, right common carotid. This one in the middle is the left common carotid, and the one on the outside is the left subclavian artery. This is just looking at a superior view. So we can see the superior vena cava coming down into the right atrium. There's the right ventricle. And we have the pulmonary artery. We have the left atrium, the left ventricle, and we see the aorta coming around here and the descending aorta going down. So normally the descending aorta goes around the heart to the left, but sometimes people have a rightward descending aorta. So we're always, when we're looking at the hearts in the lab, then we're looking at what are the connections, or the, whether it's the CT, MRI, echo, we're looking at the vessels that come off. That's just a posterior view from the back of the heart. We can see the aorta coming round. We have the innominate here, and we have the left carotid artery and the left subclavian artery. And we have the pulmonary veins coming in to the back of the left atrium. So what are the features of the right and left atrium? So when you were to look at a heart, what would be the features? Commonly we draw it as round atria and sort of bigger ventricles, but actually the atria and the ventricles are very different morphologically from each other. So we're going to look at the distinct features of each. So the right atrial appendage is a broader base, sort of like a triangular shape or a large pyramidal atrial appendage, whereas the left atrial appendage is more like a little finger. What connects to the atrium? So remember, we're thinking about, is it the SVC, IVC versus the pulmonary veins? So remember, we've had some lectures where the pulmonary veins aren't going back to the posterior part of the left atrium. And in fact, they can come down to the IVC and be obstructed, or they can come to the SVC by an extra sort of conduit vessel, or they can go intra-atrial, so they can or intracardiac, so they can go right into here. So are the pulmonary veins going to the left atrium where they should be? So there's an example of the right. So here's the right atrium. There's the SVC. The IVC is coming into the right atrium here. And we see the right atrial appendage here. And you can see that when we compare it to the left one, it is more of a sort of triangular, broad-based form. And when we open it up inside, it's kind of lined with pectinate muscle. And there's another example. So there's the body of the right atrium, but they have this big sort of broad right atrial appendage. And I liken it to when you turn a mushroom upside down and you see the filaments in the right atrium. It has the pectinate muscle, which look almost like little fine filaments all around it. And that's different from the left atrium, where you see it just mostly in the left atrial finger-like projection. We also remember in that first class talked about the coronary sinus, which returns to the right atrium. And today in the DTGA presentation, Dr. DeMarchi presented variations in coronary artery anatomy and how important it is for the surgeon to know where those cardiac arteries lie so that they don't cut through them as they're transposing the aorta and the pulmonary artery and taking the coronary arteries with them. So here's what I was describing in the right atrium. When the right atrium is opened up, we can see the fossa ovalis, and we can see the IVC. But round here, we see this sort of filamentous kind of looking pectinate muscle all surrounding the right atrium, which is different from the left atrium. There's a picture of the left atrium. So there's the body of the left atrium. There's this finger-like appendage that kind of hangs off a bit like Snoopy's nose. And it is much narrower and tubular. When you open up the left atrium, it's much smoother. And with the left atrial appendage, this sort of finger-like appendage, that's where you see the pectinate muscle lining it versus what we saw on the right ventricle where it was all around. The right ventricle also looks different. So the right and left ventricle are not made up morphologically the same. And in the right ventricle, it has muscular trabeculations. So if you were to, as Dr. Chasen would say, open up the first segment and look at the inflow tract at the base of the right ventricle, and throughout we would see these coarse muscular trabeculations. It's a bit more triangular in shape, and we have to remember that the AV valve goes with the ventricle, not the atria. So in congenitally corrected DTGA, where it's not the vessels that are corrected, it is the ventricles that are corrected, then the valve goes with the ventricle. So if the left ventricle is on this right side, then it is the mitral valve that's here. And if the right ventricle is on the left side, it's the tricuspid valve. So we should expect to see 3 cusp valve. So the other thing is that the right ventricle is septophilic. So when we're thinking about say we've got the right atrium, we've got the tricuspid valve here. And remember, the valves are to keep the chordae tendineae and the papillary muscles that are attached to them are to keep the valve itself competent when the patient or the heart goes through its systole, where it's pumping out to the aorta and the pulmonary artery. Then the chordae tendineae, which are these spider-like things that come down, attached to papillary muscle, which are attached to the free wall. In the right ventricle, there's chordae tendineae and papillary muscle that's attached to the septal wall. So it's septophilic. And so when the ventricles go through their contraction, then we want the chordae tendineae and the papillary muscles to hold the valve down shut. Otherwise, if we have damage to the papillary muscles or the chordae tendineae, when the ventricles go through their contraction, if there's nothing holding the valve competent, then it opens up and some of the blood goes out to the pulmonary artery and some will splash up to the right atrium, which then is an increased workload for the right atrium because it's dealing with more blood than it should. As well, that blood will all come down to the right ventricle. The bundle branch, so remember we talked a little bit about the conduction system before, and when the surgeons are repairing, they need to be sure that they're not cutting into the conduction system. But on the right side, we have the SA node, internodal tracts, AV node, and then we have the right and left bundle. Well, the right bundle is long and thin. So here we have our right atrium. So remember we have the pectinate muscle around it, whereas the left atrium, it just is more in the atrial appendage. Here we're showing the tricuspid valve going into the right ventricle, and we can see the chordae tendineae holding the leaflets down competent, and they're attached to a papillary muscle. So on the right ventricle, they're attached to the free wall here. And also there's one attached to the septum, septophilic. In the left ventricle though, there's our mitral valve, which has 2 leaflets, and it's got the chordae tendineae, which are attached to the papillary muscles, which are attached to the free wall, but not to the septal wall. So on that side, it's septophobic. So this was the inflow valve, or inflow tract, tricuspid valve. Right atrium would be back here, and then going down into the ventricle. And remember I said that the right ventricle, the trabeculae are quite coarse. So I always think of it kind of like a little bit of a rugged mountain. So this is the, if we were to open up the second cut in the heart, then this is the outflow tract. So we're examining all the things that we see on the outflow tract, and we see a pulmonary valve, and it's also nice and smooth up here. So 3 areas then are the inlet, the apical trabecular component where it's coarse and sort of rugged muscle fibers, and then the outflow tract where it's smoother between as you get closer to the top. In the left ventricle, again, if we were to have that heart, and one of the hearts here on the page 4, if it were opened up, that would be the inflow from the left atrium to the left ventricle. And you'd note that it's all quite smooth in comparison to the right ventricle. Again, the AV valve goes with the ventricle. So the left ventricle is on the left side and the mitral valve is on the left side. And as we said, it's septophobic. The papillary muscles only attached to the free wall. And the left bundle, so remember we said the right bundle was long and thin, but the left bundle branch is a bit more like a watershed. There's our left ventricle. So in comparison, we see our mitral valve here. So this would be our inflow from our left atrium to our left ventricle. And in comparison, the apical trabeculations are quite finer than when we compared them to the right ventricle. There's another example. We have the inlet, and we have the apical trabecular area with its finer side. Okay. So we left off here just saying that the left atrium was smooth inside with fine trabeculations at the apex. We have our inflow, our mitral valve, which is connected to the free wall and not to the actual septum, and then our outflow out to the aorta. So in summary of the anatomic features, then we have the right ventricle with its coarse trabeculae, papillary muscle on the free wall and septum, trileaflet AV valve, and one coronary artery, the right coronary artery. On the left ventricle, we have fine trabeculae, papillary muscles on the free wall only, bileaflet mitral valve, and then 2 coronary arteries, the left main branching into the left anterior descending, and then the left circumflex around the side. So there's a picture of the right coronary artery. And when we actually look at the hearts, you can see between the left atrium and left ventricle in the groove, the little coronary arteries. And there's the left main branching to the left anterior descending, and the left circumflex, which is going around the corner. So that's what it looks like. We'll see the left coronary artery. So this one's kind of twisted around, so you have to imagine that it's turned But there's the right coronary artery, which would be going off to the right ventricle, and the left coronary artery, which would be going down to the left ventricle. And so you can see the coronary arteries on the surface of the heart. And so again, the surgeon needs to be, when they're in there doing the surgery, making sure that they know the path of the coronary artery, because as you saw from even some of the previous lectures and the one this morning on DTGA, there are many variations of coronary artery patterns. Not everybody has the right and the left coronary arteries. Some people have single coronary arteries, and they take paths that may be different than normal. So here's the right coronary artery. It's got a little right ventricular artery here, and an acute marginal artery, and then the inferior intraventricular artery. On the left side here, we see the left main stem. So if there's blockages here, then our whole left ventricle is going to suffer. And this is important for when we're doing 15 leads in semester 2, because we need to think about where is the blockage. So if it's a right blockage here in the right coronary artery, then my right ventricle is going to suffer. But also you can see that the right coronary artery comes sort of underneath and tips and actually supplies the inferior surface of the left ventricle in some people. And in the right corner, in the left coronary artery here, we see the left main, and we see here the anterior descending and the circumflex going round. So they're going to have, if you have a blockage here, then we're going to have a lateral MI. If we have a blockage in the anterior descending, then we're going to have a anterior MI or septal MI. There's the coronary vein. So we're seeing that, remember, the coronary arteries perfuse the epicardial surface of the heart, and then they turn into coronary veins, which then return into the coronary sinus in the right atrium. We have the great cardiac vein that's going toward the coronary sinus. We have the middle cardiac vein, and we have the small cardiac vein over here, all returning to the coronary sinus, which dumps into the right atrium. So we need to also think about so sometimes you'll hear situs solatus and situs ambiguous and terms like that maybe aren't so straightforward, but we see them on cast sheets. Obviously for the cardiologists and intensivists, they use them commonly. But I'm going to show you at the end of this presentation how we sometimes talk, or not sometimes, on the cath sheet, we try to use language that's fairly straightforward. So all major organ systems begin their embryologic development as midline structures with bilateral mirror image symmetry. The 3 organ systems are the heart, respiratory, and digestive systems later acquire symmetry, right or left, characterized by sidedness. So atrial sidedness may be normal, so situs solatus, or the usual arrangement. And so Robert Anderson often talks about things as the usual arrangement. So where we would expect the right atrium to be on the right side, the left atrium to be on the left side. And then there's mirror image, and I'm going to show you some pictures where the right atrium, I'm just going to put the chat back on just in case. So atrial sidedness then may be normal. Mirror image, situs inversus, so the right atrium is on the left side, the left atrium is on the right side, or isomeric, where the situs ambiguous, so they may be asplenic or polysplenia. So here's the usual arrangement versus a mirror image. So we expect for atrial situs, we expect that this is the broad-based right atrial appendage, and it should be on the right side, and the finger-like left atrial appendage on the left side. And then we expect that here, we expect that if it's a mirror image, it's in the opposite direction. So that's not how we normally would expect it. An intrathoracic position of the heart and its apex that are not left-sided, or that is inappropriate in relation to the total body. So we're thinking about, what are the visceral organs that surround it? Situs, remember, means site or position. Soletus is the usual normal position of the thoraco-abdominal organs. So we expect the liver to be on the right side. We expect the spleen to be on the left side. And when that's different, how is it different? Is it situs inversus, so opposite of the reverse of normal? So it's a mirror image. So the right atrium is on the left side, the left atrium is on the opposite side, and the thoraco-abdominal, so the abdominal organs are completely reversed as well. So in right isomerism indicates bilateral right-sidedness, so that patient will have two broad-based right atrial appendages. In left isomerism, they will have two finger-like left atrium. Isomeric is situs ambiguous. Indeterminate situs ambiguous. So we're going to show you some nice pictures of that. Sidedness of cardiac, respiratory, and digestive systems is assessed separately. So for example, bilateral trilobed lungs for right atrial isomerism. So we would expect that, we have trilobed lung on the right and two lobes on the left. But when you have right atrial isomerism, we have two right atrial appendages, and then you can have bilateral trilobed lungs. So here we see the usual atrial arrangement and the mirror image. And here we're showing you what right atrial isomerism would look like. And in semester 2, one of the physicians is going to do a full presentation on the difference between right atrial isomerism and left atrial isomerism. So here we have two left atrial appendages. So we have two left atrium. In right isomerism, the spleen is usually absent because the spleen isn't on the right side. So we call that asplenia. So two right atrial appendages, and left, it can be associated with polyspenia, so multiple spleens and two left atrial appendages. So cardiac sidedness is determined by the position of the morphologic right atrium, not by the direction of the cardiac apex, position of the ventricles, or the great arteries. So here's an example of how we normally would expect to see the thoraco-abdominal organs in relation to the heart. So here we have a normal heart with the right atrium, right atrial appendage, finger-like left atrial appendage. On the lungs, we have two lobes. On the right side, we have three lobes. And when we think about the abdominal organs in relation to that, we have the liver. We have on the right side, the stomach in the middle, and then the spleen on the left side. And when we have this mirror image, so we have left atrial isomerism, so a left atrial appendage over here. So it's basically reversed. Right atrial appendage is over here, and so are the mirror imaged abdominal organs. When we're looking at right atrial isomerism, left atrial isomerism, so here we have two right atriums, and in this picture it's showing trilobed lung on the right and the left, and the midline, the liver is midline, and it can be associated with the malrotated gut. In the left side here, we have two left atrial appendages. We have two lobes of the lungs on both sides. And here we didn't have any spleen, and here we had polysplenia. So now we're looking at just a nice picture of the normal position and then the situs soletus. So we expect the heart is in the left chest. We see the right and left atrial are as they should be in the usual position, or situs soletus, the usual position, and so are the thoraco-abdominal organs. And here, situs inversus with dextrocardia. So our apex is now turning to the left, to the right, pointing to the right. And we have the left atrium over here, the right atrium here, left ventricle and right ventricle. And we have the liver that's on stomach. All right, so I think we left off here and we said the normal position, so situs, the usual arrangement, so right atrium, right ventricle, left atrium, left ventricle, liver, stomach, spleen. Here it's a mirror image, but also have dextrocardia, so the apex points to the right. And these are reversed, so the right atrium, right ventricle, left atrium, left ventricle, and the thoraco-abdominal organs are also in reverse. The situs solitus, or the usual arrangement, with dextrocardia. So the right atrium, right ventricle, left atrium, left ventricle, but the apex points to the right instead of to the left. But the thoracal organs are where they should be, whereas situs mirror inversus, or mirror image, with levocardia. So the apex is pointing to the left. And these are mirror image, right? They're reversed. And these are mirror imaged down here. So there are a lot of different anatomical arrangements. So the usual we've talked about, the mirror image we've talked about, isomeric and isomeric left atrial appendages. There could be absent right AV connection, like a tricuspid atresia, so the blood doesn't go through here, so we have to have a PFO and so on. Double inlet ventricle, so here we're having the atria both inlet into the same chamber. Absent left, so mitral atresia, so absent left AV connection. Here we're just showing a dominant RV and not very much of an LV with incomplete left ventricle. So this is the tiny little left ventricle. Here it's a dominant LV with a little right ventricle. And then here it's solitary ventricle, indeterminate. So there are two types, ventricular situs. So there's D-loop solitis, or non-inverted ventricles. Right ventricle is on the right and the left. And there's L-loop, inverted or mirror image ventricles. Left ventricle is on the right of the RV, so LTGA, or congenitally corrected. So this morning we had a nice presentation on DTGA. Later on in the course, we'll have one on congenitally corrected, or LTGA, by one of our surgeons, Dr. Osami Hanjo. So now we're going to talk about the concordance or disconcordance of the atria to the ventricle. So we've talked about the atria to the ventricle and the ventricle to the great artery. So AV concordance, RA goes to the RV, then it is concordant. LA to LV, then it is concordant. However, if we have ventricular arterial, discordance, like when we have DTGA, the ventricles aren't going to the right great artery. In ventricular to arterial concordance, the RV goes to the pulmonary artery. That's concordant. We expect that. LV to aorta is concordant. We expect that. So here we have RA to RV, LA to LV, normal concordance. This is discordant. RA to LV, left ventricle is on the opposite side. LA goes to RV. That's what we call the CCTGA. Sorry. RA to right atrium, so atrial isomerism, going to RA and LV is ambiguous. RA and LA going to univentricle. There's our tricuspid atresia, RA, LA, single inlet, right, to the ventricle, and then RA and LA going into a comlet univentricle. There's just some other images related to it, but you can see even on these images the pectinate muscle and the smooth left atrium. You can see the coarse trabeculae in the right ventricle and the finer trabeculae of the left ventricle, or the left ventricle. So RA to RV, LA, LV, we have AV, atria to ventricular concordance. Here we have RA to LV, LA to RV is atria to ventricular discordance. Double inlet left ventricle, RA, LA coming into the left ventricle, and tricuspid atresia, which we've looked at. So these are just, again, DTGA. So now we're talking about ventricular to great artery concordance or discordance. So it's not concordant for the RV to perfuse or pump into the aorta. That's discordant. It's not concordant for the LV to pump into the pulmonary artery. That's discordant. Double outlet right ventricle. So here's the right ventricle. And if we were to look at, the way Dr. Chasen describes the heart, we've got page 1, the inflow, page 2, the outflow. In this particular instance here, we would have a VSD and the aorta and the right ventricle would be coming out of the, as we're seeing here, coming out of the right ventricle. Pulmonary atresia with a single outlet. So here, the right ventricle is not going to the pulmonary artery, and it looks like it's going to the aorta. Or the previous one was the common outlet. So here we have a truncus. So we have one big valve that's going to the pulmonary artery. So out of the right ventricle, and obviously there's a VSD in the left ventricle, would be pumping out the big trunk, and you'll see the pulmonary arteries coming off. So just to look at some cath sheets, again, starting at the top, we see the SVC, IVC. We see the CVP, which was 7 here, and the mixed venous saturation, which is 75. It's going to the right ventricle. So the right atrium is going to the right ventricle. On our cath sheets, if we see a squiggly line there, it's trying to depict to us that that is the right ventricle. It's going to the pulmonary arteries. We expect that. The patient has a PDA. The 4 pulmonary veins are coming back to the left atrium, going through the mitral valve and going into the left ventricle. We know it's the left ventricle because it's smooth around the outside versus this depiction here. And then it's going out to the aorta, where we see the innominate or brachiocephalic, the left common carotid and the left subclavian. So situs, soleus, everything's in the usual position as we set it. So the atria, right atrium, left atrium, levocardia, so it's pointing to the left aortic arch, which we expect, and we have concordant AV and VA connections. So the RA is going to RV, that's concordant, RV to pulmonary artery, that's concordant, LA to LV is concordant, AV connection, and ventricle to our artery or VA connection is also concordant. Here's the tricuspid atresia here. This is a single inlet DTGA. So we see here the right ventricle, we have a big VSD, we have the left ventricle, and we have the blood coming into the right atrium. So it can't get into the right ventricle. So the right and the left are dumping in here. And we have RV to AO, right? So that is discordant. Ventricular to aorta or to arterial connection is discordant. And we have the left ventricle pumping out to the a very small pulmonary artery and a very small PA. So we have discordant connections again. So there's an example where the patient doesn't just have tricuspid atresia, but they have tricuspid atresia and DTGA and VSD. So it's characterized by ventricular arterial discordance. We can have a simple TGA or something more complex, such as DTGA with pulmonary or tricuspid atresia or double outlet right ventricle. In the 1950s and 1980s, they did the early repairs, as we saw this morning, with a mustard or a Senning procedure. And now we do the Jettine procedure or the arterial switch and move the coronary arteries across as well. Originally, babies died because there was difficulty in moving those coronary arteries to the neo-aorta. So there's our DGA that we saw this morning. So situs soleus, the atria in their usual position. We have AV concordance. We have VA discordance. We have atrial to ventricular concordance, but again, VA discordance. Same thing. So this is just saying that the patient, we kind of, if you can imagine that there's a ductus in there, that they would need to do, or they did on this baby, a BAS to increase the mixing, because that probably wasn't enough. So they did a BAS to increase the mixing. Mind you, this patient has a VSD as well. So congenitally corrected, remember the ventricles are switched. So we have AV discordance. The right atrium is going to the left ventricle. The left atrium is going to the right ventricle. That is AV discordance. Then the left ventricle here is going to the pulmonary artery. That is discordant. And the left ventricle is going to the right ventricle, which is in the wrong spot, is going to the aorta, which is discordant again. So anatomically, the left ventricle and mitral valve then are on the right side, because the valve always goes with the ventricle, and the right ventricle and tricuspid valve are on the left side. Okay, so this is just more of the same of what we've seen. So this patient was a double inlet left ventricle with CCTGA, congenitally corrected, where the ventricles are switched. This patient had a PFO and a VSD. So if we look at the diagram and begin in a sequential process, the SVC is here, the IVC is here going into the right atrium. The patient has a PFO. And this is going into, well, it's smooth around the outside, so that is the left ventricle. So the right atrium is going to the left ventricle, so that is discordant. And then this left ventricle is going to the pulmonary artery. It looks like they put a band on here. Patient has a VSD. We know this is the right ventricle because it's a squiggly line. And the right ventricle is hypoplastic, and it's going to the, it's going out the aorta. So that is ventricular to great artery discordance. We also see that the left atrium doesn't drain into this ventricle here. It's a double inlet left ventricle. So double outlet right ventricle, it describes a ventricular arterial arrangement versus a type of a cardiac defect. So remember, in double outlet right ventricle, so that's our inflow, that's our outflow, and this vessel here, both of them are on the sort of right, coming off the right ventricle. So inflow and outflow is going to go both to the lungs and off to the ventricle. So double outlet right ventricle, here's another picture. So SVC, IVC. This patient also had aortic stenosis. And here we have, they've made a DKS. So we've got the right atrium going to the right ventricle. And so situs solitus, this is the right atrium, this is the left atrium. The pulmonary veins are going to the left atrium. It's levocardia, it's pointing to the left. We have a leftward aortic arch. They've taken off the P as part of the repair and done a DKS and put a BT shunt. So there are 4 subtypes. So a future lecture will focus on double outlet right ventricle. So Dr. Mazwi was going to do it today, but we'll reschedule him. So in double outlet right ventricle, there are 4 subtypes. Subaortic VSD with a pulmonary stenosis, which is like a TET-like, subpulmonary VSD with or without subaortic stenosis or arch reconstruction resembling a TGA, doubly committed VSD, and then a remote VSD. So this is a case 1, double outlet right ventricle, had the Norwood procedure, which we just described, BT, later bicaval pulmonary shunt, and then Fontan. We don't do a cath lab Fontan anymore. And this patient was double outlet right ventricle, hypoplastic left pulmonary artery from the ductus, had pulmonary stenosis. So there's our pulmonary stenosis. So SVC, IVC, RA going to the RV. So that is the right ventricle. We know by the squiggly line. He has a VSD. And again, the outflow tract of this is double outlet to both of those. And it's not shown here, but he had a PDA as well. So level cardia, apex is pointing to the left, left aortic arch, double outlet connection, and great vessels are malposed. So the aorta is actually more anterior. So in this patient here, as a DTGA, hypoplastic left pulmonary artery, and then had a VSD and a PDA. So SVC, IVC, right atrium, right ventricle, and they did a patch closure of the VSD to the aorta. So this is the left ventricle being closed off to here, and then an RV to PA conduit to get the blood off the right ventricle to the pulmonary artery. Hypoplastic left heart syndrome, SVC, IVC, right atrium, right ventricle. We have our pulmonary artery, which is going to our lungs, our PDA. We have our pulmonary veins coming back to our left atrium, a small hypoplastic left ventricle going out to our small aortic valve and diminutive aorta until the point that you get the PDA, where we've got now flow from this ventricle, so we get a bigger size. So this is the post-op classic repair. So situs solitus, right atrium, left atrium, they're in the usual arrangement. Right ventricle, we know because of the squiggly line. This patient has been repaired. This is a heart that really, it looks like you might have had mitral or aortic atresia, no growth of the ventricle itself on the left side. But we do have AV concordance, right? And we have aortic atresia. So this is how, it's good to keep things simple, how we describe it in simple terms. So this would be from our CAS sheets. So it's balanced partial AVSD. So remember, they have a partial AVSD, not a complete. And somebody did a nice presentation last week. Abdominal situs solitus, so the abdominal organs are where they should be, where we expect them to be. Heart is in the left chest. Apex is pointing to the left. The atria are the usual atrial arrangement. AV concordant connections, so AV concordant connections, VA concordant connections, leftward aortic arch, normal systemic and pulmonary venous connections, confluent branch pulmonary arteries, and normal coronary arteries. TGA intact ventricular septum. So abdominal situs solitus, so the usual organ thoraco, abdominal arrangement, liver on the right, spleen on the left, heart in the left chest, apex in the left chest, usual atrial arrangement, AV concordant connections, VA. So the language is quite simple and straightforward. Left aortic arch, normal systemic and pulmonary venous connections, confluent branch pulmonary arteries, usual coronary pattern. Truncus arteriosus, this was a post-repair, so severe truncal valve regurgitation, free pulmonary insufficiency with a severely dilated right ventricle, but abdominal situs solitus, heart in the left chest, apex to the left, usual atrial arrangement, AV concordant connections, common arterial trunk. So remember, it's a truncus now, so it's a common arterial trunk. Left aortic arch with aberrant right subclavian artery, normal systemic and pulmonary venous connections, confluent branch pulmonary arteries, left coronary artery arises from the right posterior cusp. And finally, hypoplastic left heart variant, double outlet right ventricle with pulmonary artery. Hypoplastic left heart variant also had so hypoplastic left ventricle, mitral valve, VSD, bilateral SVCs, aberrant right subclavian artery, and hypoplastic branch PA, so the left pulmonary artery greater than the right. They did a PA plasty and central shunt, had significant left pulmonary artery branch stenosis, but the abdominal situs solitus, heart in the left chest, apex in the left. So instead of level cardia, apex in the left, usual atrial arrangement, AV concordance, and double outlet right with right ventricle with pulmonary atresia. And then, so really in summary then, understanding normal anatomy is helpful to understanding the defects and the types of complications and the flow, starting at the right side of the heart and following it through the inflow and outflow, and then the left side, the inflow and the outflow. Will help you to determine whether you're seeing things on cast sheets, for instance, that might be abnormal. So the anatomic features are distinct and different. We saw that between the right atrium, the left atrium, the right ventricle, and the left ventricle. And it's good that we're, if we're able to talk the same language is fundamental. So hopefully now you do have a bit clearer of a picture of normal cardiac anatomy and abnormal congenital cardiac variations, and a clearer view of some of the terminology that we find on cast sheets. Okay, so I'm not sure if our next speaker, does anyone have any questions? Just trying to see if our next speaker is online. Not quite yet. Okay.